All right, everyone. Well, the panel is taking their seats. Let's join them in the audience as well. Welcome back, everyone. That was our last break, but that means that our happy hour is not far away. So we have 2 more panels to get through, and then we will get to convene again and continue the great conversation that we've started here. Just as another quick thank you, everyone that's able to do some social media plugs on LinkedIn and Facebook and Twitter, it makes a world of difference. You know, this is kind of the opposite of Vegas. What happens here cannot stay here. So thank you for getting this message up and out. We really rely on that. So thank you again. Our next panel and our last panel on the 5 points is our policymaker panel. So as we've done, here's our definition. Policymakers are elected officials and departments with local, state, and federal governments responsible for crafting and implementing healthcare policy. Panelists, does that sound okay? We described you? More or less? Okay. More than less? Well, wonderful. Well, my pleasure to introduce our moderator, Carly Kiselisnik. Carly is the founder of Brainchild Technologies and the winner of our Trails competition last year, as you've already heard. At Brainchild Technologies, she brings the tools of academic baby labs to everyday caregivers so they can better track infants' social and cognitive development. It's really cool stuff. Please do check it out. With that, Carly, take us away.
Thank you very much. So I'm very excited to be part of this panel because of all the neurodevelopment, we decided to focus on hearing screening in early childhood, partly because there are such strong top-down policies, both state and federally, and we can see where those policies had a lot of teeth, and we've had a lot of success at screening babies at the hospital, and where those policies have less teeth, and we're losing kids to follow up and still missing a lot of kids. So I'm very interested in this discussion, and we're also the last group before the fishbowl, so hopefully we can just extend this in good conversation to the questions there. I'm gonna have you guys give some quick intros, so John, if you wanna start us off.
Yes, thank you. John R. Graham with the United States Department of Health and Human Services. So HHS is the cabinet level department which has a number of operating divisions with which you're familiar and some of which have been discussed today. The Centers for Medicare and Medicaid Services, the Food and Drug Administration, National Institutes of Health, Centers for Disease Control. They're all part of our department, and our secretary is Alex Azar, and it's my pleasure to represent him in this region, which is the 4 great states of Washington, Oregon, Idaho, and Alaska. And I've been in the department for about 3 years, and in this job for about 2 years, and my office is just down the road in Seattle. So as some of you know, I'm always happy to come out and meet with you all. Thank you.
And my name is Bevan McLeod. I'm the co-founder of a startup 501c4 called Alliance for a Healthy Washington. And we are working on really pushing the envelope on healthcare reform at the state and regional level. Happy to answer more questions as the evening goes on.
And I'm Bob Crittenden. I'm a family doctor. Used to be at Harborview, but also worked for Governor Gardner and Governor Inslee and oversaw the implementation of the ACA, amongst a lot of other things.
Great, thank you guys. So we're starting off with a very nice, bold question here of who are policymakers actually advocating for? Is it that patient right now today, long-term population health and economic health, taxpayer, businesses, politics? What examples of where there's balance or where it might be out of balance?
You extended the question with all these other words. I look at politics as being both one of the better parts of our system in the sense that you have the ability for the public to actually inform, I'll say, the policy-making process. And it really does happen. But I'll just let you know that a lot of things come to the legislature where there's not really a constituency, but in the sense of public constituency, but a very private constituency, which is usually sponsored by money. And just an example, I ran a pharmacy bill once just for a P&T committee, which we did get passed after 2 sessions. And we had 50 new lobbyists hired by the pharmaceutical industry against us. You win in that situation not by outspending them, but by out-organizing. And so if you have a parade and a public that supports something and you have an issue that really does resonate, and it is important to the legislators, then you can overcome the financial end of it. But it's really, I'll say it's a balance between the two, and that's why people who organize and can get together and make say a good case for the public good will win. But if you don't make that case, then you're basically defaulting to the others.
And I'm glad that you mentioned that, Bob, because that was kind of the whole impetus for us to form Alliance for a Healthy Washington, which was seeing that there were so many different individuals and organizations that are really passionate about healthcare reform in general, whether that's spending, whether that's costs, whether that's systems transparency, whatever it is. But everybody was kind of advocating individually, right? There was no umbrella organization that was bringing all of these organizations together under one umbrella to streamline that advocacy. And so that's why we decided to form Alliance for a Healthy Washington. So in kind of a roundabout answer to that question, I would say that it really depends. It depends on who the policymaker is talking to. It depends on who's walking in the door to talk to that policymaker. I think that the more education we can provide to the general public about how to get involved in policy, the more that policymakers will actually be advocating for their constituencies. So yeah, I would say it's a mixed bag.
I would say I come from the executive branch of the United States government, so we would say, I mean, we put the patients first. Now, anyone can say that. Who's not going to say that, right? But I think some examples are on prescription drug prices. We've made a lot of strides on prescription drug prices. Generic drugs, the FDA has approved generic drugs at a faster pace than ever in its history. We've seen drug price inflation go down last year. And the president actually supports the bill on prescription drug prices sponsored by Senator Grassley and Senator Wyden, who's close to home, right? So we're definitely there. There's a thing where, our Secretary Azar came from Eli Lilly, but he has criticized the drug companies quite strongly. When it comes to, there's been a lot of talk here about price transparency and interoperability of the electronic health record. We're pushing heavy on both those things against a lot of resistance. On the price transparency, both the payers and the hospitals are pushing back, but we're still pushing forward. And on the electronic health record, you might have seen Mrs. Faulkner of Epic wrote a letter to her hospitals that use her electronic health record saying they should rise up to stop our moves on interoperability. And that's not stopping us. We're pushing ahead. So thank you.
Right. I think that leads nicely to starting off the other questions on how the policymakers involved in healthcare and how it's supposed to work and how it's actually working today. So I was first wondering if, Bob, you can give us some context quickly on how we ended up here today and just kind of that brief, as you can, kind of what led to the federal or state regulations and kind of the history there.
Sure. There are probably about four major themes that have come up over, this is a long time, and I'll do a quick history, and this means it's wrong. Anytime you do a generalization, all the generalizations are wrong. So I think we started doing regulatory things in about late 1700s. We worked on smallpox, and we did quarantines, some of the colonies. And then in 1798, we formed the Public Health Service looking at semen. There was semen coming in from quarantines and things like that. So there's been a whole movement on the public health perspective, which preceded everything else. We then got involved in a lot of safety-related issues and some infectious diseases in the 1800s with not just smallpox, but TB particularly. And we had behavioral health issues come up at that time, too. In other words, mostly mental health, and it was mainly locking up people who were very mentally ill. And so we had huge hospitals being developed. And it wasn't until the 1920s or so that we actually started talking about coverage in the sense that we talk about it now. There was an effort by Franklin Roosevelt to include with Social Security a health benefit. The AMA came out against it. They dropped the health benefit and kept the Social Security, and we know it now. But that fell apart by Truman tried to do it, and then finally, when Johnson was in, they did Medicare and Medicaid at the same time. In different ways, but they did the programs at the same time, implemented them. And when I got engaged in healthcare, which was the 70s, we thought the next step was going to be a national health insurance because we just made the first step and people were pushing it, and it never seemed to happen. So a number of other things happened. Finally, with Clinton, that failed, and the ACA then was the next big move forward on that. So the ACA was our last thing, as that's been under attack for certain things. It only did 3 things, and one was the Medicaid expansion, which was huge. As far as, I'll say, the biggest social justice spending we've done in my lifetime, in the sense that low-income people can actually get health care. Second part of it was kind of I'll call them the protections. We know it as pre-existing conditions, but other protections. And those are probably the things that the average person cares about the most. And lastly, were I'll say, the subsidies for low-income people. And those are through the exchange and everything. But those are the 3 pieces that are there now. We've had, so a lot of the FDA, for instance, came out of that earlier work with drugs as well, pardon me, with safety issues, and was, I think, started in the early 1900s with the Federal Drug Act or something along those lines. And so we now have the FDA doing safety, and particularly with devices and with drugs, and we have the Public Health Service, which has expanded dramatically to get involved in other things. And we have the coverage issues, which are Medicare, Medicaid, and the exchanges through CMS.
You managed to make that pretty succinct. Thank you so much. So considering that, how are things supposed to be working today, and how are they actually working, and what's not? And maybe specifically with ACA in the combination with Medicaid, if you guys can touch on what stands out to you. Bevan, do you want to start with that?
Sure. I will say that from my perspective, when we refer to our healthcare system, it always kind of irks me a little bit because I don't see it as a system. I see it as a mosaic, right? And so there's this constant effort, and we heard from the previous panel that, you know, everybody's spending an arm and a leg, whether you're a small business, whether you're a large business, whether you're an individual purchasing off the exchange, et cetera. And so the cost is extraordinary just across the board. And so what I find is that policymakers now are trying to answer the need by slapping Band-Aids here and there. And hey, maybe if we regulate this part, we can make this cheaper. And hey, maybe if we put this thing over here, we can streamline this a little bit better. But really, ultimately, I think at the end of the day, it's only adding to the broken mosaic of what our system, quote unquote, actually is. So on the one hand, really trying to answer the needs, but on the other hand, being very short-sighted in how is this going to affect us in the long run? And is it actually going to make progress, or is it just putting a small Band-Aid on a gushing wound? So I think it's challenging to answer.
And I'm always curious that balance of having one policy that kind of fits them all versus having the flexibility and little patches for each state or local environment, and how you balance those two. So I'm curious if that's just inherent to a very large, diverse country. It's going to be different solutions in each area.
I think so, yes. Also, I think that the nature of our legislature, as an example, in Washington State is that we're on a biennium, right? And so on one hand, we have a longer session, and then the other hand, we only have a 60-day session, right? And so one year is a budget year, and the other year is not, and then you have your representatives who have to run again for office in between. So in terms of thinking about the long run, in terms of thinking about the policy and what can actually be done, it takes a lot of time, and it takes commitment, and it takes stakeholders coming to the table in between the sessions to talk to lawmakers, to policymakers about, like, hey, what is this going to mean in year 2? What is this going to mean in year 5 or 10 or whatever? And yeah, I do think it is different regionally. I mean, California has a full-time legislature, so that's helpful.
Yes, thanks. I was very, very grateful for Dr. Crittenden's description of the history going way back, because it was interesting. As it evolved, so many of these things are not really controversial, right? Like right now, we're in a fight against the coronavirus, and the CDC is working, hand in hand with the Department of Health in Washington and others. I mean, nobody says the federal government shouldn't be in that business, right? I mean, that would be, but when it comes to the health coverage, the phase we've been at for a few decades, that's where there's significant differences. And the status quo, representing the president and the secretary, we do not have a legislative change that we're proposing at this time. We have made some changes through rules on certain things. since we're talking about the ACA marketplaces, of course, and related to that, we've made some changes such as, for example, the previous panel could respond to this quite well, the health reimbursement accounts. So now employers can make deposits to health reimbursement accounts, and those deposits the individual can use to buy coverage in the exchange if the employer is not offering health benefits. Or perhaps most controversially, in some jurisdictions or circumstances would be the short-term limited duration health plans. For those people who couldn't afford to pay the premiums on the exchanges because they were of too high an income threshold to get the subsidies. There was no option for them, so we offered that option. But as you pointed out, different states have different responses. So Washington State had a very different response to that than Idaho, and Idaho's now got some action on that front. So we'll see how that rolls out. Yeah, thank you.
Could you repeat the question? I've already forgotten it.
Yeah, it was back to the what's working now and
Oh.
how is it supposed to work?
In policy
How does it
making,
actually work?
I think a lot of things work well in policy. Much as I would like to have us have a great evidence-based system, we basically use evidence very little, and we take into account politics, money, geography, a lot of things. And in some ways, we do that instead of killing each other. I mean, we get mad at somebody, and we have a way of resolving it through politics. And I think that's actually a good process. It means at the state level you have really incremental small changes. To get a bill through that is very complicated is almost impossible. We did a couple of them in the recent past, and they're heavy lifts. Even ones that were narrow but had opposition are heavy lifts. And my experience has always been with the Republican Senate and Democratic House. I left just in time to miss having both houses in the same party, which would have been delightful. But it gives you a little discipline. I have to convince somebody who disagrees with you 100% of the time to change their ways. So it was so some things that are good. I think we're able to make small changes very well. I think the place where a state has a very difficult time is making those big changes. The nice thing about the ACA gave us a structure to build on. Now, I don't think it's perfect at all. In fact, that it was not intended to be passed the way in the form it is actually in. But it gives us something to build on. We have, the biggest social justice I mentioned, Medicaid. We're able to do drug, take care of people with using opiates because of this. Mental health. In the first 600,000 people that got enrolled in Medicaid expansion, 160,000 got diagnosed and treated for mental health illness. And so you realize there were people out there floating around with no treatment options who are not able to work, not able at least to work in a place that gave them insurance, and they were just left out. You look back to the good old days, and there are some really bad things that were going on then that are now resolved because of that. I think the whole idea of subsidizing middle-income people is good. The problem is it's not enough with the subsidies, because with the cost going like this, we keep getting higher deductibles, higher co-pays, and the thing is out of control. Can we change that? Yes, but it's going to take probably a federal action to do it. To try to do it locally is very difficult to get the kind of, because we can't do competition, we can't negotiate for drugs, we can't do a lot of things that you need to do to bring the prices under. So there's limitations what states can do. The federal government has a lot of openings, though, if they wanted to take them.
Right. I've been continually interested in the focus on mental health issues and how that's coming up over time. But I do want to look at, with the current state of things, for you guys each individually, what do you think is the most pressing and urgent concern, or the one you're most passionate about? And then, as it being kind of election season, a lot of people talking about healthcare policy, is there a question or advice you would give if you had a conversation with any of those candidates?
Okay, I'm just going to be the one that goes first all the time. That's fine. So there's so many things that I'm passionate about. I will say that one of the bills that we really pushed for last legislative session was the Pathway to Universal Health Care that formed a work group under the Healthcare Authority in Washington State, and I have been appointed now to work on that work group. And so one of the things that we we're doing in our last meeting was we broke out into small groups and we defined, what is the issue, right? Well, there's issues to access, affordability, and quality, right? And then we started to go to what are the root causes, right? And we kept coming back and back and back. And for me personally, I just kept coming back to this focus of, well, we have a for-profit, system over here, but we have the human body over here. And my body isn't a cell phone. It's not a commodity. Nobody's body is, exchangeable, right? We can't just go in and say, well, you didn't fix it, so I'm going to go to a different, So the two are kind of diametrically opposed in some way, right? And it's not that one is better than the other. It's just that if you're a for-profit company, you have to answer to your shareholders. You have to answer to your profit margin. You have to answer to, the model itself. And so for me, I guess the big question is, how do we answer that? How do we look at that? And I'm not going to pretend like I have the answer, but I think that that's one of the biggest things that we need to focus on when we look at how we are going to reform our broken system is how do we answer that? And I think that public-private partnerships are really important. But I think that also looking at, Dr. Crittenden just mentioned cost. And so that is certainly a trend in, our state legislature and around the country is looking at transparency and saying, okay, so not that we can demand that a hospital charge this or a doctor charge this or a drug company charge this, but why are these the prices? And once we start being able to look at those data, I think we will be able to start answering the question a little bit more as to why our costs are continuously escalating, and therefore come up with some solutions for that. So I think that there are, definitely trends right now that are happening, at least in Washington state, and I think in other states, to really kind of tackle the question of cost, which of course dovetails with accessibility, which dovetails with quality, right? I mean, if your insurance provider is really trying to demonstrate a profit margin for their shareholders, then they're going to try and pay as little as possible for the product, right? And so then the end consumer, all of us, we say, well, where's the quality there? And we see it in the high deductibles, we see it in the out-of-network expenses, et cetera, right? So I think for me, yes, behavioral health is incredibly needed and access to behavioral health. I think also making sure that we are covering people who, live in our state. I mean, we're looking at the coronavirus right now and how quickly it's spreading. I don't think the virus cares if they're undocumented or not, right? I mean, the reality is that every single person needs access to care so that we can mitigate, health crises. So I'll stop there.
Well, I'm not sure if it's legal for me to answer your question, but that's okay. I'll give it a shot. So, of course, since I work for the executive branch of the federal government, I can't give advice to policymakers. But I would say, and also just so you know, I really should cover myself because I know you're recording this. So it's something called the Hatch Act prevents me from advocating for any presidential campaign. But of course, the presidential campaign of the incumbent president has not put forward a health reform policy yet. So as an employee of the executive branch, I can talk about what the administration's current policies are, and that law exists because, of course, I work for you as taxpayers, so I shouldn't be representing a campaign. So I can only speak for the current president of the United States, not, the 2020 campaign. So that being the case, I just want to reflect on this question of coverage and benefits, and it's not a secret that we tried to change the law, when we first came in 2017. And we didn't succeed, so we moved on to other things. And the question of Medicaid expansion is an interesting one because some states did it, some states did not do it. And when I talk to providers, they say, Medicaid expansion was great, and they campaigned, for Medicaid expansion. And that's because Medicaid is better than zero for the uninsured patient, right, or effectively zero for the uninsured patient. But then we take the next step to Medicare for all as currently proposed in the House. And again, I'm speaking about Medicare for all as currently proposed in the House, not Medicare for all as currently proposed by any presidential candidate, because that would be illegal for me to discuss that. Then they go, whoa, because there's negative margin on Medicare, negative margin on Medicaid. Not that we're satisfied with the cost structures in the provider system, but, and I'm sure the previous panel could have explained it better than I, that if you don't have the commercial payers in the mix, you've got a real problem. And when you get out to rural parts of the state or the United States, and those rural hospitals are like completely dependent on government payers, they got effectively no commercial payer, they're in a lot of trouble. So that's just sort of a general policy for your consideration.
The issue, I think, in going forward is really what's public and what's private. And by that, a community versus a private. And a lot of things you're doing, a lot of people are doing here are all going to be in the private sector in the sense they're going to be working for a company or for an insurer or whatever else. And that's probably not going to change in the near future. However, defining what our common space is huge. And how do we actually do that? I think, a number of different things. We know that the behavioral health issues was really important for us to carve out, at least get from a public perspective, get coverage for those people. Medicaid expansion was helpful. But you get into things like social determinants of health, which everybody talks about, and we do care about. But I don't think the solution is going to come from one company doing one thing, because housing is broader than that, food and transportation are all broader than that. So you're going to need to have, I'll say, a commonality, a place where we actually work together on either investing in them or in actually enacting them or doing something through either a governmental body or individually, or say in a private nonprofits or private setting, but in a community way. And I was struck a little bit by the purchaser panel right before us, and not in a negative way, but building on the first patient panel, where everybody was talking about all the holes and the problems and the gaps and the system that doesn't work, which is painful to listen to when you're a provider, honestly. But that's caused by the fact that we have so many gaps. We have a private system that is it's all siloed in a lot of ways, and how do you bridge those? But then with the purchasers themselves, the talk was about how we want to individualize, not for individuals, but per company. Each company has its own needs. And once you do that, they have no clout. They have no ability to change. And the one thing you get when you talk to every employer is, even Boeing, Greg Marchand has said, I don't have the ability to change the market. But I just, if they would agree enough on certain things, and you get all the employers lined up around something, they have more than enough clout to blow this whole system up if they wanted to do it. And they, obviously they don't want to blow it up, they want to improve it. But they could make those improvements. And so it's a trade-off between how much individuality they're willing to have for company-wise versus what they want to do in common, which would actually give them the ability to get where they actually do want to go. I find that to be frustrating, personally.
And I guess if I was going to give advice, I think, I guess I'll go down the advice route, because it's a 501c4 and I can do what I want. Sorry. Woohoo, freedom. I would say remember, and I love a lot of these candidates, but remember that nothing is free. But also remember to ask, what are we already paying? And I think that, the purchaser panel before us kind of touched on that a little bit. What are we already paying as a nation versus what would we pay under some different models that have been proposed, right? And focusing then on the savings, 5 years, 10 years, whatever, and make it about my pocketbook, your pocketbook, your pocketbook. Like, what is each individual family going to save under an alternative system? Because the reality is that we're all already paying our income tax and our Medicare tax, and we don't have a state income tax here, but we're paying property tax, we're paying sales tax, et cetera, et cetera. And then on top of that, we're paying either out of our paycheck, towards a premium. Some folks are paying on the market, on the exchange, hundreds of dollars a month, and then on top of that, they're paying deductibles. So I understand that the talking point, from the other perspective is, yeah, but your taxes will go up. And I'm like, well, I have a degree in economics. So I'm like, yeah, but what would that number be versus the total of what we're paying now in Medicare and right? And I don't know for a fact because I haven't looked at all the numbers, but I'm pretty sure it'll either be equal or less. So my point is this: rather than say free, really, talk about the savings for individuals and families.
It sounds like that goes back to the cost transparency we were talking about before. And is that an end result of policy, or is that how we start policy, of having more awareness of that?
So
look like
do
you had
we
another
need
thought.
price transparency is really important in an economic game. The real problem is who will read it and who will act on it. And I don't think patients, when they are faced with a health problem, can really act on the APCD, the All Payer Claims Database. They can't look it up and say, oh, it's more expensive here or there, even if you have all the great things come in, because they look at, they have a personal relationship with a physician or a provider. That relationship tells them, I think somebody mentioned earlier, please go to get your MRI here because you can get in the afternoon, or this is a good doctor, you should go see him. And people follow the advice of their provider much less than they do numbers. In fact, I did some research with the Pacific Business Group on health a number of years ago, and we looked at what people really, what they thought about quality. And they thought, well, quality is what my doctor tells me is the right thing to do. And then we said, well, how do you choose your doctor? Well, I asked my neighbor, and it's not like it's a real one-to-one to quality, and they don't trust numbers. Individuals don't very much, ratings and stuff like that. So I think we have a real problem with, we have problems with kind of the quality issue of how we figure out what it is quality, but we also are not, anyway, I'm going to stop there.
Okay. Can I just interject one little thing? But the other piece of listening to the neighbor is, well, I have to check and make sure that provider is in my network.
Yeah, those are all very important parts of transparency. The provider network manuals, or whatever you call them, are, they got their issues. But we're very focused on price transparency simply for the reason that we think markets work, and we don't know of any other market that works like this, where you don't know the price of what you're receiving before you engage in consuming thereof. It's just bizarre. And so the first round we had at this, basically it kind of looked like the hospitals had to kind of produce their charge masters or something. But the next round of this, which will be, it'll be coming soon, will be actually a meaningful thing that looks like you're used to kind of anywhere, And it's not like going to Walmart or something and buying something. We understand these are highly skilled services, but we buy highly skilled professional services in markets all the time. We engage lawyers and accountants and architects and stuff like that. They don't send us the bill after and don't tell us what And of course, what happens, of course, is the hospital points to the payer and the payer points to the hospital. And so we're not letting either of them off the hook. And if your market structure, which you have created between the payer and the provider, is not allowing for this, then you have to change your market structure, because we insist this is the way it's going to be. And that's for the benefit of the patients.
Just let me follow up one thing. I agree to a large extent. The issue with price transparency, though, that people who can use it are usually the organizations, the companies, I'll say the people who have both trust in the numbers, but also have the ability to drive money to different places. And I think that's really important that we do that. There's also a development in the state now. There are things called the MENS project, which is developing a clinical database out of the EHR, the electronic medical record, which I think actually has a real potential to be helpful as well. Again, it'll help for those groups like the Foundation for Healthcare Quality, BRE, and other companies who want the data on both the cost and the outcomes, how outcomes are measured. They can use it, but I don't know if individuals and patients are the ones that we hand a lot of things to the patients. Everybody talks about we're giving patient-centric, so we're giving all the information in the world, and I have a hard time understanding all the information in the world. And I think I understand it better than my mother did when she was alive. And, you know, there's no way she's going to handle all the stuff we're trying to throw at patients. And I think patients want choice. And they say, how much choice? You want 300 plans or 200? And they go, maybe 2, maybe 3. How many facts do you want? Give me one.
How about just one plan and they can go see any provider they want?
Yeah, well, yeah. Anyway, there are a lot, they want manageable choice, something they can understand.
I want to, 5 minutes. Okay. Well, we're going to skip right to really quick. So I'm looking forward. And if there has been an innovation you guys have taken on that one is your favorite, it was really successful, and was a good solution to a problem you had.
I'm going to try to, I had a tough choice of 2, but I'll go for the our response to the opioid epidemic, which has shown some success. So Congress gave us more money, you know, so this is not a place where we're being fiscally conservative, but the last year-on-year overdose deaths have gone down 4%. Prescription of opioids in the prescribing community has gone down dramatically. Access to medication-assisted treatment, MAT, has gone up dramatically. We've invested a lot in reducing the stigma and increasing the willingness of providers to get the so-called data waiver to allow them to do MAT. So we're on the right track on opioids. And of course, that gap has been filled with methamphetamine. So now we're going to go after methamphetamine. Thank you.
You know, I would say that there are, in terms of policy, a lot of quote-unquote innovations that are TBD. So we'll see in the next few years. But I would say that from an organizational perspective, social media, really, like the ability to reach out all across the nation instantly and, you know, do a kind of a call to arms and activate people to contact their legislators on a particular piece of policy is really, 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 really significant. And, you know, I work in Olympia almost every single day, and I know that it works because we hear from legislators all day, every day that, you know, oh, they're getting all this press on Twitter or they're getting this press on Instagram. The phone calls are coming into their office, et cetera. So I would say that what's really worked and helped push the needle in some capacities is that just that technology. So if anybody has any bright ideas on like specific policy ways of getting that going, let me know.
And 2 quick things, I think. One was, you say what we did that made a difference. And I think the 2 I am most proud of was I worked for the U.S. Senate back in the 80s, and we passed the first outcomes, they call it Outcomes Research Bill, and I actually wrote it. And it started now ARC and other and all the outcomes research. And at that time, we did not look at the outcomes of policies we had or of interventions or things. And the fact that that evidence is now considered to be important, even in the state legislature or any place else I've worked. So that's really been nice that's been an evolution. The other thing is, I think the state made a decision, and a lot of people here are involved in it, of getting involved in actually integrating our behavioral health with our primary care. And while that is still sorting itself out and working its way forward, I think it's going to be one of the best things we've done for the public. You know, that's a huge issue that we have. I think we're rated number 48 in mental health treatment in the state, and for good reason.
Now if we could just get dental care added.
Look at the question. Did you just lost microphone?
Uh-huh.
Okay. You can share.
I was just going to say, now if we could just get dental care added to the human body, that'd be great.
Yes. I'm same with hearing and vision as well. That would be wonderful. Okay. Great. So just in time for audience Q&A as our microphones start to fail. So does anyone have questions? Yes, in the back.
Thank you so much for your time. I'm wondering what each of you see as the role of policymakers in cures. I feel like as long as treatment is profitable, there will never be cures. Question mark.
So you're saying that if by cures you mean not the Cures Act, but actually people curing people of disease? I think there's a well, that's a good point. You know, honestly, if it's like an antibiotic, you had a 14-day course of treatment for diabetes, boy, you'd kill off a lot of the industry. I would suspect that somebody who developed that would sell it for a lot, and they'll make a lot of money, and they'd do it. So I think people will still, you know, nowadays, you've seen the cost for drugs coming up. You know, unfortunately, insulin has been one of them, but new things that like Hep C is a good example. It's actually a cure, and they just jacked the rate up way too high. I mean, we were paying $80,000 a course for a medicine that cost $80 to produce, and it was really a little bit excessive. But the point is, they got their money back, they won, and now the price has come down a little bit, and we're able to actually almost treat it as a public health issue as opposed to just treatment. So it is a cure, and so I think cures are possible. I think right now with the way we cannot negotiate, the state can't, and the federal government cannot negotiate prices, which is unbelievable. We're going to get gouged every time one of those comes along, but cures will come.
And I would just say quickly to answer your question, there's kind of a situation occurring in our state legislature right now. One of the bills that we are supporting is a co-prescription for something like naloxone, an opioid overdose medication with any prescription that is 50 MMEs per day or higher. Now, one of the leading groups that is opposing this bill is the Washington State Medical Association, because they do not want how to practice medicine in statute. So I think there's this balance between, you know, the medical community and policymakers, and, you know, you really have to figure out where that is. Now, obviously, physicians are not the ones who are the researchers developing cures, but they are practicing medicine, and they don't want prescribing written into statute. And so as long as that kind of, you know, push and pull continues to happen, I think that the policymakers are not going to dig their hands super deep into the research aspect, except for, you know, giving state money to research institutions. You know, I think that that's definitely a good space.
I would say, well, I got a lot of answers to that, but I want to be quick. So the diabetes came up, right? Well, the secretary often says, you know, we'll pay to amputate your foot, but we won't pay to, you know, for good diet or whatever, right? So in cases like that, the cure is prevention, right? We have cured a lot of things, so through many, you know, public health interventions, right? We don't have polio or smallpox anymore, and many cancer. I'm not an oncologist, so I don't want to overstate my case, but, you know, we made a lot of progress in cancer, and the President of the State of the Union announced a new initiative on childhood cancer. But the Hep C is an interesting one, right? Because the producers said, well, yeah, it's expensive because we're taking a lifetime of cost of treating Hep C out of the system. So from a net present value, we're adding, you know, it's a lower cost. And we don't know how to pay for that. So in the Medicaid program, at least one state, I can't remember the name of the state, got a so-called subscription model. So they don't have to pay all up front. They get the treatment up front, but they pay over a period of time. It looks like Dr. Crittenden has another response to that.
Well, we actually ran the numbers on that, and if they priced it at about 20 to 25, it would have paid for itself easily, and we would be able to approach it as that's 25,000 for 80 pills, by the way. We would be able to do a public health approach as opposed to a public health means you treat everybody and eradicate the disease, as opposed to treating just people who are sick or show up. And so we ended up, because of the price, we had different policies, and slowly we just weren't able to approach it the way we wanted to. So I think the idea, and that was the discussion we had in the state level, was does this pay just to do it? And they just priced it too high for that. And they hurt people a lot. A lot of people did not get treated because of that.
I think we're out of time, but we are going to the fishbowl. So I see a lot of hands popping up, and we're about to go into the fishbowl time if you guys have more questions with all the moderators up. So the question we have that will go, I think, transfer over to the fishbowl is from the patient panel to the patient. Yeah. What do you need and what do patients need to feel more involved in the policy-making process? So that can lead us off for the next session. All right. Thank you guys very much.
All right.